Hello. It's a pleasure to present to you information about kidney disease and Bardet-Biedl syndrome. As many of you know, I'm a pediatric nephrologist, and my passion and what has driven me into my desire to make a difference in Bardet-Biedl syndrome started with the kidneys. And so that'll be my presentation to you, is to talk about the kidneys, kidney health, and why it's so vitally important. Why is it vitally important? Well, the leading cause of premature death in Bardet-Biedl syndrome is kidney disease. It's number one, and it probably always will be. And therefore, we have a job to make a difference. There's some challenges as we approach kidney disease in Bardet-Biedl syndrome. The first challenge is, unlike so many other features of Bardet-Biedl syndrome, we don't have a good animal model. So the zebrafish, the mouse, or any other animal model trying to look at kidney disease has been terribly insufficient. And so we're left without models that we can work with. We can't examine a mouse and the therapies that we might give to it to see if it makes a difference in the kidneys, really. There might be some subtle issues, but it's not a very good model. So what do we have? We have the Clinical Registry Investigating Bardet-Biedl syndrome, which is a long-term natural history record of kidney health and BBS. We're using that even right now to better understand kidney disease, to understand the genetics of kidney disease, because as you know, we're always interested in understanding, do certain genes or certain modifications make a difference? And we're working on that. So your participation in CRIBS is vitally important. In the near future, I'll be reaching out to all those who have had a kidney transplant or need a dialysis to ask for you to contribute your DNA for some special testing that we're going to do, whole genome sequencing, to figure out if we can find some more genetic predictors, because it's so vital that we identify those individuals who are at risk for kidney disease. That will make a big difference, is if we can target the right people with the right interventions to make a difference. Well, before I go on too much further about the future research, I want to talk about what we know now. And so I want to talk a little bit about what the kidneys do. And so the kidneys. Most of us are born with two kidneys. They reside in our back area. The kidneys are constantly working. They know no such thing as a vacation. They filter our blood and clean of all the impurities. They're like the master housekeeper for any home. They constantly clean those impurities out of our body. They also remove acids from our body. Our body produces acid as we metabolize our foods that we eat, and throughout our daily life, we make acid. Our kidneys clean those acids out, and they also make something that's called bicarbonate, which is an antacid that gets rid of the acids our body builds up. The kidneys control our blood pressure. They direct our body to make new red blood cells. We call that, when we have a lack of red blood cells, we call that anemia. And the kidneys produce something called erythropoietin to make our bone marrow make new red blood cells. The kidneys clear our body clear drugs from our body. So as we take medications, they break down and they need to be excluded, they need cleared from our body. And the kidneys, as well as the liver, do a very important role in doing that. The kidneys also have a role in modifying vitamin D. Vitamin D is something we talk about a lot. Vitamin D is crucial for so many functions of the body. We, of course, think about it with our bone health and that. It seems to have a lot of other functions. And the kidneys have an important role in modifying vitamin D from an inactive into an active vitamin. So that's a very important role the kidneys play. Now, in Bardet-Biedl syndrome, there tends to be two types of features that affect the kidney health. One is what we call structural abnormalities of the kidneys. Another one are functional responsibilities of the kidneys. And so I'll be talking about that. Some of you were told, our parent mothers were told before you gave birth to a child with Bardet-Biedl syndrome, that the kidneys looked different. The kidneys looked bright, or they might use the word echogenic, and they oftentimes mix up that appearance with something called autosomal recessive polycystic kidney disease. Those two diseases are sister conditions. They have much in common, but they have a lot of difference in common. Individuals with autosomal recessive polycystic kidney disease, often the kidneys keep getting bigger and bigger and bigger during the pregnancy, and when the child's born, they often have severe high blood pressure and poor kidney function. In Bardet-Biedl syndrome, on the other hand, the kidneys are the most echogenic, usually about 20 weeks of gestation, and throughout the pregnancy tend to become a little bit less bright, and they don't keep growing. So at birth, they tend to be near normal, if not normal in size. And that appearance of brightness with the kidney tends to improve over time, so they become more and more normal looking. Now, some people with Bardet-Biedl syndrome still have that brightness to the kidney that remains there throughout their lives. The other structural issues of the kidney include there may be an absent kidney, there may be what we call complex uropathies, where there may be a complete merging of the genital and urinary tract, so that tract where in a woman that the uterus is connected to the vagina, as well as where the bladder is connected to the urethra, can all be merged into a single sinus we call the urogenital sinus. That's probably the most complex uropathy we see in BBS, and it's relatively common. We see milder situations such as a blockage within a kidney, which we call hydronephrosis. We see it sometimes in an absent kidney where the kidney doesn't form. We also see a fair amount of something that's called vesicoureteral reflux. That's where the urine backs up out of the bladder into the kidney. Many individuals with BBS get recurrent urinary tract infections. In those individuals that do that, if you have that problem, it's important for you to get a test called a voiding cystourethrogram to know if you have that reflux, because sometimes that needs to be treated. And recurrent urinary tract infections are more common in BBS for lots of reasons, and we want to deal with that and treat it appropriately. Also, the kidneys in Bardet-Biedl syndrome can have cystic changes that are pockets of urine within the kidney. Now, unlike some of the other diseases we call ciliopathies, remember Bardet-Biedl syndrome is part of a group of diseases called ciliopathies. Unlike some of the ciliopathies, such as the very common disease called autosomal dominant polycystic kidney disease, or the less common but often confused disease, autosomal recessive polycystic disease, where you have many, many cysts that keep developing over a lifetime and ultimately destroy the kidneys. In Bardet-Biedl syndrome, typically there may be 2, 3, 5, maybe even 10 cysts per kidney, but rarely are there multiple cysts that keep on growing in size and basically displace the normal function of the kidney. That would be very, very atypical of the renal disease of Bardet-Biedl syndrome. If by chance you do get that, please call me. I'd like to talk to you a little bit more about you or your family member that has that. And so that's the structural issues of the kidney, and they do require ongoing monitoring and treatment, sometimes urological treatment for it. Okay. But now I want to talk about the functional parts of the kidney, because that's going to be where the action's really at, okay? And so the functional part of the kidney is, first of all, our kidneys have to maintain the right fluid balance of water within our bloodstream. They do that on a regular basis, making sure that we don't urinate too much or that we don't urinate too little. And so the kidneys do that. We do that by what we call concentrating or diluting our urine. And that's a very important function. Okay. The first investigators of Bardet-Biedl syndrome back in the 1980s identified that as a common abnormality in Bardet-Biedl syndrome. So what they found is that people with BBS don't concentrate their urine or dilute their urine as well as they should. Dr. Beals, in his really landmark paper on defining Bardet-Biedl syndrome and the clinical criteria back in 1999, labeled people with BBS as having nephrogenic diabetes insipidus. I want to explain that and explain to you what he was describing and why we use a little bit different term nowadays. Nephrogenic diabetes insipidus. Well, diabetes does not mean the sugar diabetes, but instead a diabetes where you make too much urine. Okay. In the classic form of diabetes insipidus, that's a completely different disease from BBS, and those individuals simply don't respond to a hormone that our brain produces that makes us concentrate our urine. And those individuals are usually boys, and they're usually discovered very early on in life. Sometimes that can develop later, usually due to drugs, such as lithium is a classic example that can cause diabetes insipidus. In Bardet-Biedl syndrome, on the other hand, the problem is that those little hair cells, we call the cilia, that are in the tubules of the kidney, they don't get the message right. And so basically they allow the body to make too much urine when you really shouldn't be doing that. And so we see that commonly in BBS. And that happens in people of all levels of kidney disease. So even if their kidneys are working great and they've got BBS, they have that problem usually. And if they don't have, and they can have advanced kidney disease and still make too much urine. So actually, that's kind of a take-home point. So even when you are making plenty of urine, you can still have significant kidney disease. And so that's why you need to be checked on an annual basis to see how your kidneys are doing. And so that impairment of concentration, ability of the urine to concentrate in people with BBS is extremely common, nearly universal. That's why some of you notice that you're drinking more than your friends and they're urinating more than your friends. Parents, that's why some of your children wet the bed until late adolescence, is because of that extra urine output that is common in BBS. A second feature of BBS that is affected by the kidney is the inability of the kidney to get rid of acid as well as it should. We call that renal tubular acidosis. And some people with BBS will need to be on a supplement for bicarbonate, such as sodium bicarbonate or common baking soda, to treat that issue with the renal tubular acidosis. Unfortunately, some individuals will ultimately lose more and more function of their kidneys in a quiet process that people may not recognize that lead on to kidney failure. And so I want to talk about the kidney failure of BBS and why it's so important that it be monitored. Kidney failure in BBS is not typical of other forms of chronic kidney disease. When I see my other patients that don't have BBS, that have kidney disease, they usually have a lot of protein, a lot of blood in their urine. They have a puffiness of their ankles or puffiness of their body we call edema. They get a lack of appetite. They just lose their appetite. They're not hungry anymore. They also typically, with other forms of kidney disease, they often lose energy, and they become more and more sedentary and lose interest in life. And so that's what we see in a person with typical kidney disease that goes on to kidney failure. They get the dwindles, as I say to my patients. You get the dwindles. It's time for us to talk about transplantation. In BBS, we don't see those features, and this is why it's so very important that you see your kidney doctor on an annual basis for kidney evaluation. And for some of you with more severe kidney disease, you need to see them more often, depending on what your nephrologist tells you. But in those individuals with BBS, first of all, they always make plenty of urine. Until the very, very last time of your kidneys are working, you're still going to be making plenty of urine. So lack of urine output is not a part of BBS. The second thing is the urine very seldom contains much of any red blood cells in the urine. If you do, that needs to be investigated for other causes. There may be some protein, but never severe enough that it causes that edema that I explained as fluid retention within the body. In addition, people with BBS, even though they might have advanced kidney disease, still have their appetite. And so something we as kidney doctors look for is lack of appetite, but that always is preserved in BBS. And finally, the sense of I don't feel good doesn't usually affect people with BBS. They feel typically just fine, even with their advanced kidney disease. So those cardinal symptoms that your nephrologist may ask you about may not be there. And again, that is why it's so very important that you see your kidney doctor on an annual basis to have your kidneys checked. It's critical, and it's really very much encourage you to do that. Now, when I meet with people in the Center for Excellence for Bardet-Biedl syndrome, and I review with them kidney health, I usually give them a letter of hints that I want them to follow. So many of you can't come to see me in the center, and so I want to go through those hints with you and give you some guidance on what you can do to protect your kidney function and make a difference for you. The first is drink plenty of fluids. It's essential that you drink fluids all throughout the day to protect your kidneys. It is a very important thing. Again, my preferred thing for you to do is my preferred beverage is water. Juices are fine, but on the other hand, juices have calories and will make you gain weight, and so I don't encourage juices usually. Flavored water is perfectly fine. Caffeinated beverages such as Coca-Cola, Pepsi, and so on should be avoided because they act as diuretics or water pills that can work against us and make it so you get more dehydrated. So I encourage plenty of fluids. Parents of children with BBS, you might find that your child would do better in school if they're allowed to have a water bottle and free access to the ability to drink water and use the restroom when they need to. Why is that? Because they get thirsty. And thirst is a very much part of a BBS. And as you know, many people drink a lot with BBS. If they're in school and the teacher says you can't go you can't go to the water fountain or you can't take a water bottle with you, they're going to have trouble concentrating in school because they're thirsty. And if they're thirsty, how can they focus on the math lessons or on the other class topics that are being given? So please work with your teachers to allow your child to take a water bottle with you. If you need to, ask your doctor to provide a letter that says to the teacher, this is vital to their health. If you have questions about that, reach out to me and I'll try to work with you on it. Second thing that I encourage people, as I mentioned, many people with BBS have bedwetting. Sometimes doctors want to treat that with something called DDAVP. It's a medication usually given before bedtime that makes it so the kidneys concentrate the urine. That substance is probably a poison to the kidneys in BBS. It's fine for people that don't have BBS, but in people that have BBS, it is probably a very negative impacting drug on your kidneys. And so I'll say this again, strongly encourage you not to give your child DDAVP for bedwetting. It will work against you. The next thing is the importance of treating high blood pressure if it's present. It's extremely important that blood pressure can be well controlled. We know that good control of the blood pressure makes a difference in kidney health of all forms, including BBS. Now, when your doctor thinks about prescribing a medication for you, I'd like to encourage your doctors to use something that's called ACE inhibitors or angiotensin receptor blocking agents, ACEs and ARBs. ACEs end in pril, such as captopril, lisinopril, and enalapril. ARBs in the syllable tan, such as valsartan, irbesartan, losartan. Those medications have been clearly shown to make a difference in people with a sister ciliopathy called polycystic kidney disease, and they make a difference in BBS. So I encourage you to use that as a drug of choice for your blood pressure management. There's a variety of other drugs that your doctor can use, and I want to tell you why I don't encourage them in BBS. The first drug of choice that the doctors might prescribe is something called a beta blocker. Propranolol, metoprolol, labetalol are examples. Unfortunately, those medications tend to slow the metabolism, and so on average, people gain 1 to 2 kilograms a year by taking a beta blocker. And so weight is your enemy with BBS, and so excessive weight gain and obesity is your enemy. And therefore, making a person take a medication that's going to have them gain weight works against you rather than for you. And so I just strongly encourage you to avoid the beta blockers. There's a group of medicines called diuretics, such as hydrochlorothiazide or chlorothiazide. Those medications promote more urination and work against the issue of this high urine output or polyuria and polydipsia in BBS. In addition, they may increase the risk of diabetes mellitus developing over time, so that's sugar diabetes. And so I strongly discourage the use of diuretics as your choice of medication. Finally, there may be some detrimental effect of amlodipine, which is what we call a calcium channel blocker in BBS. And so I discourage those drugs. And so again, the use of ACEs or the prils, lisinopril is my favorite drug, or the ARBs, which is such as valsartan, would be the drugs of choice for the treatment of high blood pressure. And it's important to have good blood pressure control. I unfortunately have heard from some parents that their doctor said, well, we just want you to eat less salt, and that will control your blood pressure, so just do that. That doesn't work. Obviously, eating too much salt is not good for you, but just putting someone on a low-salt diet, we call the DASH diet, is not adequate therapy alone for Bardet-Biedl syndrome and hypertension. The next thing I'd like to point out is there's a group of drugs used for acid reflux. They're called proton pump inhibitors. Such proton pump inhibitors include omeprazole, Nexium, and the like. Those drugs taken for years will lead to kidney disease and kidney damage. And so If taking it for a short period of time, a month or two, might be fine, but I strongly discourage the long-term use of these things called proton pump inhibitors. Another drug that I like to discourage, I need to give a little background. Constipation is very common in Bardet-Biedl syndrome. It is extremely common. And so many patients take Miralax and the like, and those are fine. But sometimes people with BBS get so constipated that the GI doctor recommends a Fleet's enema. A Fleet's enema is something that's done through the rectum. Unfortunately, Fleets can cause significant damage to the kidneys in people that are prone towards kidney disease. So I strongly I encourage you to avoid the use of Fleet's enemas. People sometimes ask me, is it important for me to be on a special diet with BBS? My answer is eat a wise, well-balanced diet. I'm a little bit concerned about the ketogenic diet when it comes to BBS because it emphasizes so much high-protein diet, which is a little harder for the kidneys. And so I'm not a big fan of the ketogenic diet. I know for some people that you do it and it works. But if you have significant kidney disease, please just be aware that I'd rather you not be on that. And then the thing I've said already several times, but I'll just emphasize it again. It's so important you get regular evaluations with your nephrologist to make sure your kidneys are doing well. It's just really critical. Now, in some individuals, kidney transplantation or dialysis is necessary. I want to emphasize that people that can receive dialysis just fine and they can do well with it. It works. If it's necessary, it's a necessary therapy that should be done. One of our challenges with Bardet-Biedl syndrome is weight. And unfortunately, many times people, even with end-stage kidney disease, have a weight that makes it so hot that their body mass index is too high to get a kidney transplant. That's a challenge. I am delighted with setmelanotide because I think it's going to be a treatment for the obesity and advanced kidney disease. We're currently working to establish the clearance of the drug in people with advanced kidney disease. There are studies currently going on, including at the Marshfield Clinic, to look at that drug clearance in people that are non-BBS patients with chronic kidney disease, so we can predict the ability to use the drug in people with advanced kidney disease. Because I think it will be a game changer for people on dialysis who can't get a kidney transplant because their body mass index is over 35. So I think that's going to be very important. I also think that weight loss for people that have advanced kidney disease may also have a significant impact on improving kidney function. I'm hopeful that that's true. For those that get a kidney transplant, congratulations. Please take your medicines on time, just as directed by your nephrologist. Work with your nephrologist on that and be adherent to the therapies that are given to you. Weight can be a huge issue. About 3 years ago, we published a paper looking at weight patterns in people with BBS after transplantation and found that that was a real challenge. It's a super challenge. And so I'm hoping that setmelanotide will be available for people with kidney transplantation in the near future because I think that weight loss would be of tremendous benefit to them. So today, I've talked a little bit about kidney disease. I've told you what the kidneys do. I've told you why it's so important in BBS that we address the kidney health of people with BBS. Why? Because it's the leading cause of premature death. It can affect your health in so many other ways. Plus, so many features of BBS affect the kidneys. There would be diabetes or high blood pressure or so many other things. I've given some hints to you that you should take back to your doctors with guidance on ways to help protect your kidneys in the long run. I hope this information has been helpful to you. Please feel free to reach out to me with questions. I'm always happy to try and answer those questions to my very best ability. I know some people have reached out to me and I've not always gone right back to you or overlooked an email. Please email me twice. Sometimes I get busy and forgetful. But I'm here to help you. That is my goal in life. And finally, my plea to those people who need dialysis or a kidney transplant, if you'll reach out to me because I'd like to work with you to do what's called whole genome sequencing to see if we can find potential genes that will help us understand why you had kidney failure and what made you different from other people with BBS. So thank you for all of your efforts to support the work here at the Marshfield Clinic and to be part of CRIBS. Again, I give you my heartfelt thanks for all you do. Thank you very much. Well, it's been a wonderful conference. We had the opportunity to hear from very wonderful speakers. You heard from Nico Kasanis and his enthusiasm, his insight, and his wisdom. I look forward to seeing what Nico will bring forward in his coming years of research and activity. I'm excited that there are therapies that are on the horizon that he's describing, medications that may already be on the market that may have a significant benefit for people with BBS. I look forward to hearing more from Nico in the coming years. We heard from Arlene Drack. Arlene obviously is a wonderful pediatric ophthalmologist who's championed gene therapy. I'm hoping to see that on the market sooner than later too. What a wonderful blessing it is to restore sight to someone with BBS. As some of you might know, I have a daughter that's blind. She does not have BBS, but she's blind. If I could give her back the gift of sight, that would be a very special gift I would love to have her have. I'm excited that there's a therapy, such as gene therapy, that may be available to you with having BBS. I hope to see Arlene's work to be very successful. We heard from Greg Gordon and from the team of Rhythm Pharmaceuticals about setmelanotide. I'm excited about it. As you know, I'm probably his biggest fan because I've seen such great success, and I hope to see it become available commercially so that you can receive the drug regardless of what country or state or location you might reside in. I think it will make a difference. You heard from Dr. Offenwanger, who gave some great insight on ways to behavioral care that is so vitally important in BBS. You've heard from Tammy Timler with some practical guidelines on wise diet that is so very important. We heard from BBS, from Rhythm, about the path of finding a diagnosis of BBS. I hope that was insightful to you. Your own path was probably a little bit different. Each one of us have a different path in life, but I don't think that was a wonderful opportunity. You've heard from Dr. Pomeroy and his research about exercise, sleep patterns, and so on in BBS. It's exciting to see. You have heard from me about kidney health and from others with information that's beneficial to you. I want to express my appreciation to each speaker who has contributed to this conference. It is wonderful. Now at the closing, I need to reach out and with my thanks to Sonia Suda, the BBS coordinator for the Center of Excellence for BBS. Sonia has been the individual who has done so much work to make this conference possible. She rarely gets the recognition that she deserves. So thank you, Sonia, for all your work. And thank you to the Marshall Clinic Health System that has sponsored many of the events here, including this virtual conference, to make it possible for us to bring this to you. I want to express that deep appreciation. I also express my thanks to Bill Alms, who has also made videoing possible to bring some of the presentations to be. So thank you to all those individuals. I'm sure I've overlooked someone. I want to express my thanks to the BBS Foundation here in the United States that has supported so much of my research and my activities. I deeply appreciate them. And I express my appreciation to all of you who have made personal contributions to my work here at the Marshall Clinic. I'd be delighted to continue to receive your assistance in what we're trying to do. Even small donations make a difference as we try to do research. I promise you that every single penny you send to help support CRIBS or any other research here at the Marshall Clinic will be used 100% for advancing BBS and our care for individuals with BBS. So thank you. Now in conclusion, I just express my appreciation to you as individuals with BBS or family members of people with BBS. You're wonderful people. As I've said so many times to people, I've never found a mean person with BBS. You're all wonderful. You're all terrific people. Thank you very much, and we hope this conference has been beneficial to you. Have a good day.